very much for the introduction. I'm happy to be here again for the second year. It's been a great conference, and thanks to Roland and Vivian for their slides ahead of time, just so I can make sure that we were aligned in our topics. Let me know if you don't see my slides proceeding. I think I've now opened up 2 versions, so I'm just going to proceed on this version, which is the second tab, and let me know if you don't see the slides proceeding. So I'm going to focus on AML, MPNs, and actually a little bit of MDS. Okay, here are my disclosures. So the first question, just to get the venetoclax elephant out of the room, make sure that everyone's paying attention. In the randomized phase 3 trial that Roland discussed, recently published, comparing azacitidine and venetoclax to azacitidine and placebo in untreated AML, patients ineligible for induction chemotherapy, what was the survival benefit in the venetoclax arm? A, 1 year, B, 9 months, C, 5 months, D, 2 months, or E, no survival benefit demonstrated. Okay. And should I be able to see the answers, or?
Yes.
Okay.
So after
sure. So I think there is a time limit of 15 minutes on the poll. So I think people will probably take it. I don't know if you're going to be able to see the answers in real time.
I see. Okay.
Yeah.
Okay.
I suggest you move forward with the discussion and the teaching points, and people will probably keep taking the questions as they go.
Okay, sounds good. All right. So the answer in this case was C, 5 months. And Roland showed this figure on the left, the survival curve. The median survival was a little bit over 14 months in the azacitidine with venetoclax arm, and 9.5 months in the azacitidine arm. Here are the response rates table on the right. The CR/CIR rate was over double in the venetoclax arm as well, at 66% versus 28%. The median time to response was lower in the 1.3 or so months compared to 2.8 months. And the median duration of response in the combination group was 18 months compared to 14 months. The rate of transfusion independence of both platelets and red blood cells was also higher. And we'll get a little bit into subgroups as well. So question 2, on the same trial, which patient subgroups benefited the most from the combination compared to the placebo? Patients over the age of 75, patients with higher ECOG scores, patients with poor risk cytogenetics, patients with TP53 mutations, or patients with IDH mutations, or A and E, age over 75, or those with IDH mutations, or B and D, higher ECOG or TP53 mutation. Everybody, a minute or 10 seconds. So the answer is A and E, patients over 75 years of age and those with IDH mutations. And as Roland showed this figure as well, this is kind of the money shot from this paper. Older patients here appeared to particularly benefit with a hazard ratio of 0.54, as did patients with a better performance status of less than 2, although those, older than 2, were benefited, greater than 2 benefited as well. Patients with IDH mutations did particularly well. Although patients with the TP53 mutations did have a hazard ratio of 0.76, the confidence interval was wider, and there was fewer patients treated in that arm. So question 3, this is a little bit about MDS, which we didn't touch on too much today, but just a little bit of an update. The drug APR-246 is being evaluated to reactivate a commonly mutated gene in MDS and AML that has historically been a challenging drug target. Which pathway does the drug control? Epigenetic regulation, B, tumor suppression, C, normal early hematopoiesis, D, the RAS pathway, or E, RNA splicing, spliceosome mutations. All right, and the answer is tumor suppression. So TP53 mutant MDS accounts for 5 to 10% of de novo MDS and probably closer to a third of therapy-related MDS, and represents a distinct molecular cohort with very poor outcomes similar to AML. APR246 is a first-in-class molecule that selectively induced apoptosis in mutant TP53 cancer cells through p53 protein reactivation, thus restoring wild-type conformation. There was phase 2 data at ICAHO by the GFM French group, which I will not try to pronounce that, of APR246 with azacitidine in TP53 mutated AML and MDS patients. 38 had had 3 cycles and were considered evaluable for response. And response rates were 53% CR, CRI, 11% marrow CR, and with a median follow-up of 8.5 months, the median overall survival had not been reached. Neurologic toxicities were the most unique side effect to this drug, which we're seeing also, we have one of these trials here, and it's certainly the case. Patients complain about feeling a little bit drunk, ataxia, cognitive impairment, confusion, dizziness. And in 3 of these cases, it was grade 3. And then there was a phase 1-2 trial of this combination also presented at ASH in 2019 in 45% of patients with similar response rates, 53% CR, and there was 18 marrow CR with HI. The median survival in that group was almost a year. So there is now an ongoing phase 3 trial in MDS of azacitidine plus Aprea versus azacitidine alone. It is not placebo-controlled. It has just completed the enrollment. So we will look forward to these results in the next year. The next question, in what setting has the recently approved CC486 or Onureg shown to have efficacy in hematologic malignancies? A, untreated AML patients unfit for induction chemotherapy. B, hypomethylating agent refractory MDS. C, post-remission therapy in AML for patients unable to complete intensive chemotherapy. Or 4, ruxolitinib-resistant myelofibrosis. So the answer is 3, post-remission therapy in AML for patients unable to complete intensive chemotherapy. So as you heard a little bit from Roland, CC486 is an oral hypomethylating agent recently approved for AML patients who have achieved CR or CRI following intensive induction therapy but are not able to complete intensive post-remission therapy. The QUASAR trial was a multi-center randomized double-blind placebo-controlled trial of 472 patients age over 55 in first remission after induction or consolidation, randomized to receive CC486 or placebo orally, days 1 through 14, Q28. 45% of patients had received 1 consolidation, and 30% had received 2 consolidations actually prior to starting. The median survival at a follow-up of 41 months, overall survival was 24.7 versus 14.8, favoring the CC486 group. And the median exposure to CC486 was 12 cycles. The most frequent adverse events were GI, mostly grade 1 to 2. And GI AEs led to discontinuation in only 5% of patients, and quality of life was actually similar in both arms. So they did also do some dose escalation at the time of relapse, and that was effective in about a quarter of patients. And this led to the approval recently of this drug. Question 5, in the phase 2 pharmacokinetic pharmacodynamic randomized crossover study between IV decitabine and oral dazuridine and decitabine, or INQOVI, that led to the approval of this agent for MDS and CMML, what was the primary finding? A, higher response rates for oral decitabine compared to IV. B, systemic exposures and pharmacodynamics were similar between IV and oral decitabine. C, oral decitabine had a better safety profile than IV decitabine. Or D, once patients got their hands on the oral decitabine, they left the country to live out their lives in the Caribbean, never to see their oncologist again.
D is the obvious answer there, right?
Yes, so it is actually B. Unfortunately, they haven't, because of the trial specifications, they haven't left yet, but maybe they will. So the primary outcome of this trial, which led to the approval, was showing similar systemic exposure. So this trial was adults with intermediate 1, 2, or high-risk MDS or CMML. They were randomized 1-to-1 to receive oral decitabine with this enzyme that allows for a decreased breakdown and improved exposure of the decitabine, or IV for the first cycle. Everyone crossed over for cycle 2, and then after cycle 2, all patients received the oral version. There were 80 patients treated in this trial. There was another trial that had a little bit more patients as well. And the primary endpoint was mean decitabine AUC systemic exposure, which was met. And these are just showing different exposures on different days of day 1 and day 5 of the IV and oral drugs, showing similar mean decitabine plasma concentrations. So 21% of patients achieved a best responsive CR with a median duration of 13.3 months with an overall response rate of 60% for the whole cohort. This first figure shows survival between the different sequences, A and B, and I actually, frankly, don't remember which sequence was which. There was no difference. But of course, people got oral decitabine for the majority of the trial, so it was not comparing efficacy. And the second figure shows time to best response. Although responses were seen as early as the first cycle, most responses were manifest by cycle 3 and could take up to 5 cycles for best response. Of the 38 patients who were red cell transfusion dependent at baseline, 50% became transfusion independent, and also 50% of the 12 platelet transfusion dependent patients became platelet independent. The incidence of AEs during cycles 1 and 2 were similar between oral and IV of all grades, including grade 3, and there was no increased GI AEs in the oral decitabine compared to the IV decitabine, which may be a little bit different than CC486, which has a different mechanism of improving oral exposure and seems to lead to more GI toxicity. The main limitations of the study, however, were there's lack of safety and efficacy outcomes between IV and oral over a longer period of time. And the paper concluded a parallel arm randomized design between oral and IV decitabine would require a prohibitively large number of patients to prove sufficient power to show non-inferiority based on clinical endpoints, as everyone would have a preference for the receive oral treatment. And that argument seemed to be enough for the FDA. So we will, moving forward, start to see this drug used more, and especially, I think, in combination with a lot of our other agents. Question 6, which new therapy being developed for myelofibrosis is targeting a patient population with a platelet level of less than 50,000? You heard about many of these from Vivian. A, CP0610, a BET inhibitor. B, fedratinib. C, momelotinib. D, ropeginterferon interferon. E, PI3K delta inhibitors. Or F, pacritinib. So the answer is pacritinib. So pacritinib is a JAK2 FLT3 IRAK1 inhibitor in development. There were promising results from 2 phase 3 trials, PERSIST-1 and 2, but there were concerns for excess death from intracranial hemorrhage and cardiac issues, which led to PAC203, a dose-finding study that was presented at ASH this past year, looking at 100 daily versus 100 twice a day versus 200 twice a day. 5 patients with a CR of over 35% at the 200 milligram BID dose, 4 had platelet counts of less than 50,000. So, which was a response rate of 17% in this population. And so they concluded that they saw their best responses in patients with severe thrombocytopenia with platelets less than 50,000, and the AEs were more manageable. And then this led to the choice of dose in the ongoing phase 3 Pacifica trial, which is now open, of randomized MF patients who failed ruxolitinib and platelets less than 50,000 to pacritinib 200 milligrams BID versus physician choice. This has stricter exclusion criteria for prior bleeding and cardiac history, as did the PAC203 study. And this was just the figure shown that Vivian showed as well of the SVR at week 24 by dose. As you can see, responses were actually quite small in the lower dose arms, and even, you could say, in the higher dose arms, responses were generally low. And in those, further, the endpoint of over 50% symptom reduction, again, in the range of 7% in all group, although they argue that the median change of negative 27% was the most in the 200 milligram BID group. So the last question, luspatercept was recently approved for beta thalassemia and MDS. It's being studied for the treatment of anemia and myelofibrosis. What is the mechanism of action? Transforming growth factor beta inhibitor, glycoprotein hormone that stimulates erythroid progenitor cells in the bone marrow. It's an inhibitor of the hedgehog signaling pathway, the spliceosome inhibitor, or it incorporates into DNA and promotes DNA methyltransferase. In the interest of time, it's A. So luspatercept is a novel fusion protein that blocks transforming growth factor beta superfamily inhibitors. It reduces aberrant SMAD signaling and enhances late-stage erythropoiesis as compared to erythropoietin. That it works earlier in the pathway. 2/3 of patients, MF patients, have anemia. Many do require red blood cell transfusion, and we really have limited therapeutic options. The JAK inhibitors seem to not improve anemia, and in many cases worsen it. This was a phase 2 study of 74 MF patients with a hemoglobin of less than 95, plus or minus the need for red blood cell transfusions. There were 4 sort of complicated cohorts, either on or off Rux and needing transfusions or not. And luspatercept was dosed as we dosed MDS, starting at 1 mg/kg every 21 days. And the primary endpoint was either increase of hemoglobin by 1.5 or transfusion independence for that group. And this was the primary endpoint in blue and the secondary endpoint response rates. Here are the cohorts below, and these are the 2 Rux groups. And as you can see, the response rate seemed a little bit higher in the ruxolitinib groups. And so that we'll be having ongoing development, and that is the end of the questions. Thank you very much, everyone, for joining today.